My name is Dr. Benjamin Inti. I currently reside in Indianapolis, Indiana, the United States. I work at Riley Hospital for Children at Indiana University Health, which is part of Indiana University School of Medicine. It's a standalone hospital, and I've been there for a few years now. My current role is a clinical assistant, uh, professor of clinical and emergency medicine. And introducing ultrasound into what I do is very important. I use it primarily as an extension of my physical exam. And so then I'm able to disposition my patients a little bit quicker. And there are some patients that do not need additional imaging, but I'm able to enhance my clinical assessment at the bedside, making me more a little more efficient. In the world of pediatrics, we tend to see a lot of illnesses such as respiratory symptoms and issues. Um, and I think that's probably the predominant one we encounter. We also encounter a lot of soft tissue infections. Um, and then, of course, in the emergency department, which is native to this, just the trauma that you would get. As you can see, the point of care ultrasound in the emergency department is very important. And now we have tools that allows us not at the outset just to use it for trauma. Now we're able to use it for pneumonia or any respiratory presentations that arise, including I mentioned that the soft tissue infection. Those are sort of the core things that we find that we're able to use the machine or the ultrasound modality for. The challenges that we usually face are the size of the patient, and then just certainly their age. And with each patient that comes in, we have to understand what our limitations are, where the ultrasound can be helpful, and where we can possibly use our clinical judgment to make a quick assessment efficient and be able to disposition the patient. So the challenges really lies within the patient and their presentation, but it's really difficult because each patient is different and the size is different, as opposed to when you look at general medicine, it's sort of this one size fits all, but in peds, it's really focused. When assessing the lung, I find the lung diagram on the venue family to be very useful and very important now, because prior to this, what we used to assess the lung was more of a segmental approach. But now the venue family has allowed us to be able to have the diagram at the bedside and be able to see everything at once, be able to make a quick and efficient assessment of the patient. And it gives you a whole picture as opposed to the piece by piece meal fashion that you tend to see previously. So I think this is a very much an enhancement and a step forward in the right direction. I'm a big fan of the long sweep. I was drawn to the venue go, starting with the long sweep, and it really helps to take the guesswork out. So I am fellowship trained in point of care ultrasound, and I'm able to acquire the images, and that's fine. But I find that when I'm teaching at the bedside, it takes some skill for my learners and my certainly faculty as well, my colleagues, to be able to adjust to that. But now we have the VenueGo family that allows you to see all the pleura on the anterior portion of the patient, the lateral, and then the posterior on both sides. It's really turned the image acquisition on lung on its head a bit, where now you can see all the views in different orthogonal planes in one sitting at the bedside. So in fact, in a sense, you're seeing sort of a 3D from the anterior, lateral, and posterior at the bedside, and you're able to assess all of that at once. And I think it's fantastic. The respiratory conditions that are very supportive of lung sweep, I think it's important because we're trying to get even better at diagnosing pneumonia at the bedside. Now, we know that lung ultrasound outperforms the chest x-ray when looking for pneumonia. Um, with the VenueGo family, we're able to now hone that in a little bit more, focus that, and how we can even increase our specificity, if not to 100%, as close as possible, sensitivity and the specificity. In doing so, I found that when there is a consolidation, for example, that let's say sits on one portion of the pleura, you're able to use the long sweep to assess that entire consolidation, as opposed to having one segment at a time to be able to connect the dots and see where it is. And I think that that really helps, because then you can see it in each plane of the patient, and that has made a difference for me, at least at the bedside. That goes with pleural effusions as well. I think it's been very instrumental during the epidemic as well. So I think this is a way forward and is the future of long ultrasound, and I'm certainly excited for it. The need for X-rays with point of care ultrasound, I think for me, I've reduced the amount of X-rays that I'm getting now. Um, the only thing that's holding me back from being full out point of care ultrasound is the culture, and you're getting a slow buy-in with the rest of the hospital. So if I'm able to admit a patient, I say this patient has a significant pneumonia, and they need to be on IV medications, and they need to be admitted for it. In most cases, there's going to be a question of where's the chest X-ray. Well, even though our system is able to incorporate point of care ultrasound into the electronic medical record, and so people are just so used to seeing the chest X-ray. They are it's become the second nature to them. It's going to take several years to kind of unwind that and show them, even though the evidence is out there for point of care ultrasound, that we can use this, and this could certainly replace it when we're looking for specific questions about whether a patient has pneumonia or they do not have pneumonia. And so I think that's taking some time. But for me, I think we've seen a decrease in the amount of chest X-ray that we get, for the large part, most because we know our pretest probability usually isn't great before we get these chest X-rays, but we still want to make sure that this child isn't sent home with a significant disease. So for that reason, you find a lot of doctors ordering chest X-ray. Well, now long ultrasound could answer that question for you right at the bedside, and so you can disposition the patient from there. The minimum probes that you need, I think for peds, any pediatric point of care ultrasound person could probably tell you that you could get away with so much with just a linear probe. Currently, what I have with my VenuGo is the L12, and it's fantastic. Any of the linear probe, as long as it's not a hockey stick that we use for maybe things like peripheral IV, but even then, you can probably get away with using it. But at minimum, you need a linear probe. And I think it helps because the AP diameter of the child is not that huge. And so the depth isn't that great, but you're able to see everything, and it's very enhanced. You get a clarity of the picture. Even sometimes it might be a bit of an overcall in terms of some of the noise that you might get with artifacts. And that certainly can be adjusted on the machine as well. But I think having the linear probe is very important. I use it for all my, not just the long sweep, but just for acquiring, even if I was just to do a segment of a window, just looking for whether it be pneumothorax or pneumonia or effusions or anything like that. But that's where I think your starting point needs to be for pediatric scans with lung. I don't have one favorite transducer. I like all my linear probes equally because I think they do a great job. There might be some clarity, of course, with each different transducer, and I think that's for anyone who's using it at the bedside to decide which one they like more. But I tend to like all of them so far. I've enjoyed using the VenuGo quite a bit, and I think when the VenuGo was being manufactured, it was well thought out. First, it's a touchscreen interface, and it's built for the future. Well, with the millennials and the new age that are coming up in medicine, it's such a cool machine. And I think my students right now have enjoyed it. And anytime I have it in the emergency department, there's an immediate question of, whoa, what is that? And it's different from the current machines that we have, because the current machines we have, they have the keyboard, and then the laptop kind of feel to it. Versus the Venue Go, everything is in front of you at once. It's very sleek in its design, so I'm able to maneuver it to the bedside very easily. It fits in small spaces as well. And then the placement of where the transducers are up on top, very friendly, easy to use and reach. Also has the gel pocket right next to it as well. And then the basket is at the bottom, and it's good. It's a little platform for you to place things on. Let's say if you want to do peripheral IVs at the bedside, you can actually put stuff right on there. And then we get to turning on the machine and just starting with the interface. It has different features. If you want to get really involved in your scans, you can do that. If you want to just start immediately and tell the Venue Go, I just want to start scanning right now, it'll allow you to do that as well. If you want to learn about the diagrams that you're using at the bedside, you can do that as well. I think one of the features that I saw that was fantastic, I think my learners love, is the renal ultrasound, where it has different levels of hydronephrosis right there, and is able to tell you. We certainly love the fast diagram as well, and able to tell you exactly where you're scanning, also record those pictures, and then allows you to determine whether it's a positive indeterminate scan or if it's a negative scan. So I think it's great. It's a well done machine, the Venue Go.